Myasthenia gravis, chronic autoimmune neuromuscular disease. Chronic, which just means illness lasts for a long period of time, and autoimmune is when the body immune system mistakenly attacks healthy parts of the body. And neuromuscular actually tells us what the part of the body is affected. Myasthenia gravis is a neurological condition in which body fails to transmit nerve impulses into the muscles, so they get weak with repeated motions and activities. Actually, myasthenia gravis affects only skeletal muscles, so voluntary movements are affected. The cause of problem arises from antibodies that are produced by person's immunity, which interfere or block nerve impulses, leading to symptoms of the disease. Myasthenia gravis can occur at any ethnic group, any age, and in both genders. Although it's more common in young women in age about 40s and older men in age around 60s. This disease is even called the disease of young women and old men. Even the newborns can have it, and that disorder will be called transient neonatal myasthenia gravis. It happens when the mother has the disorder. Myasthenia gravis in newborns generally produces feeding and respiratory difficulties that develop about 12 hours or a few days after the birth. It is happening due to presence of mother's antibodies in baby's blood, but symptoms will disappear in a few months, like 2 to 3 months. They will disappear due to they will be destroyed by baby's immunity. Myasthenia gravis is considered sporadic disease, which means it's strike at random and it doesn't run in families, so it can be inherited. Approximately 20 people per 100,000 of U.S. citizens are diagnosed with that, but still this disease is considered underdiagnosed because symptoms of myasthenia gravis are really similar to many other neurological disorders. The autoimmune reaction underlying myasthenia gravis results from a malfunction in the immune system in which the body produces antibodies that attack specific receptors located on the surface of muscle cell. These receptors are found at the neuromuscular junction where nerve cell interact with muscle cell. Under normal condition, a nerve cell stimulated by a nerve impulse releases the neurotransmitter acetylcholine, which crosses the neuromuscular junction and binds to a receptor on the muscle cell, thus triggering a muscular contraction. In myasthenia gravis, antibodies bind to the receptors, preventing acetylcholine from binding to them, and thus preventing the muscle from responding to the nerve trigger. This slide describes the chain of action of the myasthenia gravis curse. The reduction of neuromuscular transmission occurs in 3 different mechanisms. Direct blocking of acetylcholine receptors on muscle cell, direct attack with destruction of them, and destruction of postsynaptic surface on the muscle cell, which leads to reduced number of acetylcholine receptors. And this slide is a perfect depiction of the difference of neuromuscular junction between normal cell and one which is affected with myasthenia gravis. On the left side, you can see how many acetylcholine receptors are on the muscle cell and how big the surface of it. And on the right side, actually, there is so less, and the surface is really minimal. The thymus gland abnormalities are clearly associated with myasthenia gravis. 10% of patients with myasthenia gravis have a thymus tumor, and 70% are having hyperplastic changes, which are indication of hyperactive gland. However, it is still uncertain whether the role of thymus in the pathogenesis of myasthenia gravis is primary or secondary. Patients with thymus cancer usually have more severe disease, higher level of acetylcholine antibodies, and more severe abnormalities that in comparison to patients without problems with thymus gland. Usually in such cases, thymus gland is going to be removed. It is now done robotically, and the result of the surgery that 1/3 of the patients are completely cured. Another third has to remain on a low dose of medications, and another third has no changes at all. That's why the relationship between Myasthenia gravis and thymus disorder are still uncertain.
When classifying the extent of the disease, this is the scale that is usually used. Class 1 is considered someone with ocular weakness. Class 2 is mild weakness. Class 3 is moderate, and Class 4 is severe weakness. These classifications also branch into subgroups, with A indicating predominantly limb or axial, and B consisting of mostly oropharyngeal or respiratory weakness. Class 5 is the most advanced stage of MG, and that's when the patient has to be intubated, either with or without ventilation. So, what causes myasthenia gravis? It could be caused by insufficient secretion of acetylcholine, excessive secretion of cholinesterase, or unresponsiveness of muscle fibers to acetylcholine. Okay, so some signs and symptoms of myasthenia gravis. The patient can have what is called a mask-like effect, which is when they appear sleepy due to weakness in the facial muscles, arms, and legs, and they also have chronic muscle fatigue. Other symptoms include weakness of laryngeal and pharyngeal muscles, which causes difficulty swallowing and chewing, choking, aspiration, and slurred speech. The first symptom that occurs is ocular weakness. This can result in ptosis, which is drooping eyelids, and diplopia, which is double vision. Ptosis is depicted in the picture to the right of the slide. This weakness tends to get worse with activity and improve with rest. In advanced cases, patients can have bladder and bowel incontinence and even respiratory failure. A person with myasthenia gravis can have an exacerbation when exposed to triggers. These include exertion, heat, emotional stress, the postpartum period, surgery, menstruation, infections, and certain medications such as aminoglycosides, ciprofloxacin, chloroquine, procaine, lithium, phenytoin, beta blockers, procainamide, and statins. So let's look at how MG is diagnosed. We can take an antibody blood test, and we're looking for anti-acetylcholine receptor antibodies when we do that. An MRI or CT scan can also be done. Another test that is used to diagnose MG is a single fiber electromyography, which is an electrodiagnostic technique for evaluating the electrical activity produced by skeletal muscles. We also use a nerve conduction test, and what that consists of is repeatedly stimulating a motor nerve and recording compound muscle action potential from a muscle that is innervated by that nerve. The adrophonium, or tensilon test, is when the drug tensilon is injected. If the muscles get stronger following the injection, it is considered a positive result for MG.
There are two complications of myasthenia gravis: myasthenic crisis and cholinergic crisis. Myasthenic crisis is an acute exacerbation, a life-threatening condition, which happens when the muscles being used for breathing become very weak. As a result, it can cause severe breathing problems and can lead to lung failure, often implementing intubation or the delay of. Certain things trigger this, such as respiratory infection, surgery, emotional distress, pregnancy, exposure to drugs that may increase myasthenic weakness, or beginning treatment with corticosteroids. It is caused by undermedication with anticholinesterase. The increase in myasthenia gravis symptoms can result in greater difficulties due to acute exacerbations such as swallowing, diplopia, ptosis, and dyspnea. Your priority as a nurse should be to maintain adequate respiratory function, hold the meds to increase secretions, remove the secretions, and perform a tensilin test. It helps to determine improved muscle contractility after an IV injection of indrophonium chloride, which this is the tensilin, an anticholinesterase agent. This is also used for a cholinergic crisis, which I will discuss next. A cholinergic crisis is an overstimulation at a neuromuscular junction due to an excess of acetylcholine as a result of the inactivity. In other words, the muscle weakness is caused by over-medication of anticholinesterase drugs. The muscle twitches to the point of respiratory compromise. In this case, as with myasthenic crisis, our priority is to maintain respiratory function. Symptoms can improve with anticholinergic medications, such as atropine. In addition, you should hold anticholinergic drugs while the client is maintained on a ventilator. Observe for thickened secretions. Atropine can be given repeatedly to dry these secretions. Improvement is usually rapid after administration. Symptoms would be diaphoresis, diarrhea, fasciculation, cramps, marked worsening of symptoms resulting from over-medication. Fasciculation is a quick, spontaneous contraction that affects muscle fibers. It causes flickering of movement under the skin. This slide just reiterates the causes and differential diagnosis between the two crises. The causes for myasthenic crisis is under medication generally, and cholinergic crisis would be over medication. The differential in myasthenic crisis would be improved strength after medication is administered versus cholinergic crisis, it would be weakness. And both would have increased weakness of skeletal muscles under signs and symptoms. There are several treatments that can be administered. One would be anticholinesterase. The med would be called pyridostigmine bromide. It is the most popular and most successful long-term med. It is given to enhance transmission and the neuromuscular junction. The antidote would be atropine. When you take the medicine, you should take the medicine every day. If you have discomforts in GI situations, take it with milk or food. Drug therapy is a lifelong and requires family teaching and support. You should observe for symptoms such as fasciculations, abdominal cramps, diarrhea, incontinence of stool or urine, hypotension, bradycardia, respiratory depression, lacrimation, and blurred vision. Corticosteroids suppress the immune system response. The med that would be given would be prednisone, which inhibits or prevents activity of the immune system, used for short periods of time unless the patient is experiencing ocular complications. Another med would be immunosuppressive agents, which inhibits or prevents activity of the immune system. The following meds listed on the screen would be the ones that you would use for that section. Intravenous immunoglobulin is a high dose of IV immune globulin, a blood product concentrated with antibodies that's extracted from healthy donors. It's administered through a vein to treat immune system disorders or to boost immune response to serious illnesses. A thymectomy is a surgical removal of the thymus gland. It may reduce symptoms, but the effects may not be seen for many, many months after surgery. Plasmapheresis is the removal of the affected blood plasma and replaced with a good plasma. A plasma exchange is very similar to kidney dialysis. It is done daily for a period of time.
A few nursing diagnoses related to the patient with myasthenia gravis include ineffective airway clearance related to intercostal muscle weakness and an impaired cough and gag reflex, risk for aspiration related to weakness of the laryngeal and pharyngeal muscles, impaired physical mobility related to muscle weakness, risk for imbalanced nutrition, less than body requirements related to difficulty swallowing, and ineffective breathing pattern related to weakness of the respiratory muscles. Patients with myasthenia gravis are typically hospitalized due to a respiratory tract infection or are in an acute myasthenic crisis. Care for this patient includes monitoring respiratory status. Changes in respiratory status can indicate respiratory failure. Assess the patient's ability to cough and deep breathe effectively, as this can help mobilize secretions. Have a tracheostomy kit available at the bedside in case of aspiration due to myasthenic crisis. Administer cholinergic drugs as prescribed and monitor for symptoms of cholinergic crisis, which include abdominal cramps, diarrhea, incontinence, hypotension, bradycardia, respiratory depression, and blurred vision. Schedule nursing activities to conserve energy. For example, daily hygiene activities, administration of meds, and treatments should all be done at once if possible. Allow frequent rest periods and plan activities in the morning when energy levels are high. Allow for adequate bed rest as this often relieves symptoms. Monitor for myasthenic and cholinergic crisis and report immediately if either are present. As patient educators, we as nurses should instruct the patient to avoid situations that produce fatigue or physical/emotional stress, as stress can exacerbate symptoms. Teach the patient the importance of wearing a medic alert bracelet. Teach the patient about a balanced diet that can be easily chewed and swallowed. Semi-solid foods are usually easier to eat than solids or liquids. Help the patient plan activities of daily living to avoid fatigue. Teach the patient about the importance of adhering to the medical regimen. Help the patient schedule doses of drugs so that peak action is reached at mealtime, making eating less difficult. Refer the patient to MG support groups if needed. A few key points to remember include symptoms of MG are highly variable between patients. Not everyone will have every symptom, and the degree of muscle weakness can change from day to day. The severity of the symptoms typically increase over time if left untreated. Out of all MG patients, only 14% remain with ocular symptoms only. Weakness progresses during the first 2 years that involve oropharyngeal and limb muscles. The maximum severity of MG is reached within 1 year in 55% of cases and within 5 years in 85%. The most dangerous aspect of MG is so-called myasthenic crisis, respiratory compromise due to muscle weakness. Respiratory failure requiring ventilation can occur in severe cases.
These are our sources, and that concludes our presentation. Thanks for watching, guys.